right, we are going to move into the last part of our federal agency roles and progress reports, and we're going to have Dr. Jolie Crowder start us off with IHS.
I am so glad we took a break because all I could think about is 3 o'clock is when everybody's blood sugar drops, and then they're sitting here listening to talk about more facts and figures and those kinds of things. So I appreciate that and appreciate the coffee. Thank you so much. I got the operator button here. Do I? Maybe? Am I a little? Oh, got it. All right. I'm really excited to be here. Many of you know Dr. Bruce Fink, who was a representative for eons, it felt like, since the beginning of time. So I'm very excited. This is the second time I've represented the agency at one of these meetings. So like everyone else, all of my federal colleagues, just wanted to give folks a little bit of background about the agency. I feel like we're a little unique maybe, but we probably all do in our roles. So the Indian Health Service is the agency or a sub-agency of Health and Human Services. We're responsible for providing health services to American Indian and Alaska Native people across the country. We are a provider first, direct care and services. We also are a payer of sorts, and I'll talk a little bit about that system in a couple slides. So, the agency and the funding by Congress grew out of government-to-government relationships that were codified in the Constitution, treaties, laws, Supreme Court decisions, and executive orders that said the United States needed to make due on their promises and provide health for American Indian and Alaska Native communities in exchange for land and those types of things. So our mission is raising the physical, mental, social, and spiritual health of American Indians and Alaska Natives across the country. We really take that spiritual part it's very important to us in all the work that we do. Let me see, flip over. So about Indian Health Service, it doesn't sound as cool to say we're the 18th largest health system in the United States, but it feels pretty cool to be that system that is the 18th largest health system in the United States. We serve 2.8 million American Indian and Alaska Native people from 575 tribes. I was excited that the last one that made its way in was in Virginia, and I've watched that as a resident of Virginia. Those tribes exist in 37 states. We have a system that has 12 areas in 37 states, and even for the IHS facilities, care is very local. So you'll see a slide later that says culture is also local. So if you've seen one facility, largely you've seen one facility. We have a budget of about $5 billion, which sounds like a lot until you look at the number of people we serve and relative to the other agencies. Not my program. My program has a very little bit amount of money. So just a quick primer on what the ITU system is. So we talk about Indian Health Service, which is the federal agency, and there are 3 parts, and oftentimes you'll hear us talk about the ITU system or that acronym. Indian Health Service, so we have our own facilities, primary care clinics, hospitals, those types of things that we staff and fund with federal employees. And then we have tribally operated, so that's the T in that. And as of 2025, I think 65% of our budget goes to tribes to decide how to take care of their folks locally on their own. We also fund 41 urban Indian health organizations. That is a system and a program that's woefully underfunded since 70% of American Indian and Alaska Native people no longer live on reservations and tribal communities, but doing the best we can with the funds that we get there. Typical services, maybe, I think when we first started as an agency, we were prevention and public health. You'll see we still, a lot of our budget actually goes to sanitation. We have people who don't have running water. I think we had somebody from Alaska who came last year and spoke to the group. We have people without running water. We have many people who don't have paved roads. There are homes without electricity, and so some of our funds go to building that type of infrastructure in communities. In addition, we do all of those things plus dental services, nutrition. What's kind of cool about a lot of our clinics is it is all of those services in one many times. And so if you can get them in the door, then you can also get them to dental care and pharmacy in ways that you might not be able to do otherwise. On the right, you'll see a big part of our budget and funding goes to purchase and referred care program. Many people who are American Indian and Alaska Native don't look fondly upon this program because we often run out of funds and it's very restrictive purchasing. It means that if you can't, I don't have a neurologist in my system, my tribal system or the IHS system, then I will pay for you to go see a neurologist in another system. But if we run out of money, then we can't do that. So it becomes a very rationed situation of care. The tribes also have the ability to, once they receive funding and submit a plan, the tribes can offer other services. So you will often see in that whole notion of once you've seen one tribe, you've only seen one tribe. So you could walk into any clinic and get a different perspective on how those folks are providing that care. Our workforce is 14,000 employees. It should be, I think, 15 or 16,000. We've run about, I think at the peak of this year, it was 37% vacancy rate, mostly in our clinical, in the clinic type roles because of a variety of reasons. So we are chronically understaffed, which creates a lot of challenges when you want to go talk about Alzheimer's and dementia, when they're dealing with triage and critical care type situations. We see a lot of patients in the work that we do. We do have hospitals, so we have some inpatient admissions and 14 million outpatient medical care visits as well. I've already touched on the challenge of recruiting and retaining healthcare staff. And in every single area, they exist. We have our own loan programs. We've tried to create infrastructure similar to what HRSA says, and it's still a challenge. It's always a challenge to convince somebody to go off the beaten path where there might not be electricity or water to serve those types of communities. And I've said it, in the cultural context, you've seen one tribe, you've seen one tribe. In the same way, if you've seen one facility, you've only seen one facility. So I encourage you in your communities to make connections, come visit. We have a meeting next month, come visit and meet the people from our communities as well. I'm actually not sure that this is necessarily unique, but the cultural significance of elders and tribal communities, I revered my grandparents. I think we all do, but I think in a way, in a perspective, that our communities view their elders, like we use that term, not in a pejorative way, is a little bit unique. And who we consider an elder isn't conveyed by age. It is sometimes the wisdom and experience. And that's often because their life expectancy is so much lower than that of the rest of the population. So I have a lot of color, I think, on my slides compared to the other folks, but not a lot of graphs. So we were funded. We got money the first time in 2021. It took about a year to get staffed up through 2022. We put some grants out pretty fast at the end of that year. I have, I think, a slide with our staff on here. We're a pretty small program, I think, relative to some other agencies and their funding for these types of areas. We really ground ourselves in our communities and our people, and we see the work that we do as walking alongside of our communities. We have cooperative agreements for that reason, not because we want to tell you how to do the work as part of a cooperative agreement, but because we want to help you walk that path together. And so a core of our work is creating relationships with the communities that we serve. And these are photos taken with a little bit of our funding over the last year in the communities that we've worked with and have grant funding. Our 4 priorities, I think they're pretty similar to kind of the public health wheel and some of the other things that you might see from other agencies. I think what's unique to our agency is we also do the work at the direction of the tribal communities we serve. So we have to engage in tribal consultation and urban confer before we can do anything. So they gave us money, and then it took us a year to talk with tribal leaders and urban Indian health leaders, who then said these are our 4 priorities. I tried to create the little chart based on money and like how much we're spending where. Number 1 out of the gate with us was grants and program awards, so getting money into the communities. The appropriations language said, go build a model of care, and we quickly found there is no single model of care. What we did is fund programs to create models of care, and we're still in the evolution of that process. The other big piece is workforce development, training, and education. I think Joan spoke. We've used a lot of the HRSA materials, their GWEP grantee materials. Sometimes we're the funnel. Like there's 2,000 things that happen out there, and I can't get a primary care provider to pay attention to, an email with lots of things. So we have to funnel it. We have to make it relevant to the work that they're doing, and we have to figure out the right space and time for us to get the primary care provider's attention. We also do some outreach and awareness, so that's our lovely little graphics. Principally, our work in this space is really focused on creating awareness. I think stigma is in every community, but particularly so in really small communities when the person who works at the front desk is probably your cousin. You don't want them to know your business. And so that makes a big difference in how you provide your care. The other work we do is the boring, what sounds kind of boring, but the program support and data on the bottom. Like, data should drive all our decisions, right? I'm a nerd, so I like data. We're doing some things like creating a dashboard internally. We have spent 3 years. We still can't get an accurate count of the number of people who have a diagnosis of dementia in our health system. And people come to me all the time and they're like, can you give me data? And I'm like, I really can't, because it's not quite that easy. So those are our 4 priorities. This is our amazing team. Nicole's our boss. There's myself, Valerie, and actually Jamie, we're full-time. And then Dr. Bellantoni, who works in the Phoenix Indian Medical Center, is our consultant. We get about 10% of her time. When I was counting up for another slideshow the other day, we have 18 things we're working on, not little things, but big things, pilots, programs, and initiatives, because we're all just so passionate about the work. We have a family member, we have personal experience, those types of things. So we're always looking to do something more, better, different. As I mentioned, the big thing is grants. I loved Aaron's map. We have a little map of our models of care grants. So far, we funded 18 communities. Pretty much all over the United States. We were glad in our last batch we got some over on the East Coast. Practically speaking, most of the tribes are on the other side of the country, which is why you don't see a lot of dots over here. So these are just some of the things that our grantees have done. And it might seem really basic to you to say, oh, you put together a memory care basket and you gave it to the caregiver, and it might seem really simplistic as a grant-funded activity, but those folks need that sort of care and support and connection and resources, even big or small. We've had the things that our grantees are doing are really big, but they're also just sort of that personal connection in their community to change hearts and minds. We have so much more funding stuff that we do. For instance, we're on our 3rd cohort of working with community health reps, which is the tribal corollary for the CHW workforce. We've done a mini-cog pilot and been really successful at training CHRs to do screenings in the community and then get them into the primary care clinic. So excited about that. A lot of you saw on that chart, a lot of our money, how am I doing on time? Go faster? Okay. I'm coming in there. I could talk all day, but that would be boring. We don't do a lot of policy, and we don't do research at all, really. If we do, it's epidemiologic research. The closest we come to policy in our program and in our work is we create a dementia care pathway. It seems like the most basic thing you could do in the world, but if you were a doc and you tried to go out into the universe and figure out how to diagnose somebody and what that conversation looks like next, it didn't really exist. You'd find yourself in a random PDF on the internet. Or I had a doc who said I printed out a journal article from AAFP, and that's what he was using, is flips those pages every time a patient came in. So this is really simple, stripped down, bare bones. Some of our last recommendations, no offense to the neurologist, but are you really don't have to see a neurologist for a diagnosis. And so that's really got to change hearts and minds in that space. So that came out this year. We started up recently a dementia clinical support line. You got a patient, you have a question, call us. We're still trying to get the word out, but we've heard from nursing homes, we've heard from primary care providers, lots of folks who are just like, I don't know what to do next and I'm stuck. So that's been pretty successful as part of our support area. We are rolling out right now quarterly dementia trainings. Congress said we needed to do quarterly competency-based training, so we're doing that for all of those folks. Anybody who's ever tried to get training through and approved at the federal government will commiserate with me that this has been a labor of love to get all of this content out, and it will be free and available to anyone, but our audience is particularly American Indian and Alaska Native serving people. We have a couple programs, Jerry Scholars and a Jerry Nurse Fellowship modeled after a VA program. We're literally changing hearts and minds of community one provider at a time and one nurse at a time. We have some videos. We have some more awesome videos coming out, so maybe we'll share those links with you when they come out. Our big push has been the mini cog, just letting people know it exists and showing them how to use it. We do echoes. Again, Congress said go do echoes, so we're doing those echoes, but they're really helpful in terms of support for our communities. And come to our summit next month. We'd love to have you. It's in Denver, and hopefully it won't snow in March. We have 2 days of great content. Our grantees will be there, so we'd love to see all of you guys there to learn about the work that we're doing. Contact us, join our listserv, email me, and I'm done.
Thank you. That was a lot of information in a short period. Thank you, thank you, thank you.
I'm from the South, and I talk really fast,
I loved
too.
it. I loved it. Thank you so much.
All right, we are now going to turn things over to Kevin Cheney with AHRQ.
Okay, let's see if I can get the clicker to work. I'm from Southern Ohio, so it's kind of like the South. But I have more of a slower, but I'll try to keep up the pace, and so we'll see what we can do. Again, my name is Kevin Cheney. I'm a senior advisor at the Agency for Healthcare Research and Quality. I support our Division for Digital Healthcare Research. And this is my first time here at this meeting, and so it's very exciting. And I take over for Dr. Arlene Bierman, who was previously heading the agency's work here. She is hopefully enjoying retirement. And I also want to say that obviously what I'm presenting to you is a lot of work from a lot of really incredible people at the agency and the researchers that we fund. So real quick, I'll go over, you heard a little bit today, earlier today, Dr. Klein talked about AHRQ's mission. I'll probably skip the leadership part since you actually got to hear from him today. And then I'll go into what our current research priorities are, kind of how are the different ways that we help improve outcomes for the American people. And then I'll talk about more of our recent work in support of ADRD. So AHRQ is a component, obviously, of the United States Department of Health and Human Services, and we're dedicated to health services research, the field of study that examines health care as it is delivered to patients, examining the quality, safety, and affordability of health care delivery. AHRQ conducts and supports patient safety research and supports the use of state-of-the-art data analytics tools to analyze and improve U.S. healthcare system. AHRQ conducts and supports research into improving health outcomes, evaluating the strength of evidence for medical procedures, treatments, and preventative interventions, and investigating ways to improve healthcare treatments. So we do a lot of different things. Just as a kind of a quick historical tidbit, we just celebrated our 35th anniversary, so we're relatively new compared to some of the other agencies, centers, and offices around the table here. And also just to let you know, from a budget perspective, right, NIH and some of these others in the billions, we're about $350 million as a total budget to do a lot of the things I just mentioned in our mission. So we are obviously supported by our tremendous leadership from President Trump down to Secretary Kennedy, and as well as Dr. Klein, who joined us last summer, and we were very glad and grateful to have him leading us in the direction of the agency. So what does that look like? So some of our research priorities, obviously, within the name and what I've talked about earlier, but really focused on improving patient safety, the effectiveness of healthcare for all Americans, and core areas include reducing medical errors, improving diagnosis, medication safety, and promoting appropriate care, including antibiotic stewardship and the responsible use of medications across all ages, but in particular for children. And we're also advancing digital health, telehealth, artificial intelligence to expand access and strengthen evidence while reinforcing the scientific rigor through real-world data integration, reproducibility, and innovative study methods. I also want to highlight that at AHRQ, we're prioritizing high-impact conditions. And that includes things ranging from obviously long COVID, autism, nutrition, and chronic disease prevention, with a shift towards solution-oriented research that delivers measurable improvements in health outcomes. And across all areas, we remain committed to training the next generation of health services researchers. So how does AHRQ do what it does? So the first thing that we do is we look to generate scientific evidence and actionable knowledge. So this is through funding health services research, extramural research grants, contracts, et cetera, that help us understand how care is delivered, how it can be delivered better. Cost, quality, safety, value. We also work to help move evidence into practice. You heard Dr. Bateman talk about earlier about the fire hose amount of data and information, and how do we help try to speed that up? Well, that's one of the things that we try to do at AHRQ is look at what the evidence is, and is there things and ways we can do to develop tools, trainings, resources, and assistance. And I also note that AHRQ, we are a non-regulatory agency and obviously non-punitive. So the types of things that we look and oversee is not within the realm of FDA or CMS or some of our others. We also have a lot of different data repositories and different data that is utilized across the healthcare system, from HCUP, healthcare costs and utilization, to MEPS, medical expenditure panel survey data, CAPS, consumer assessment, and healthcare providers and systems data, as well as a robust number of other data sets, such as patient safety databases, et cetera. And so certainly one of kind of the three-legged stool, if you will, of all the different things that AHRQ does to try to help develop and push evidence into the field. Okay, so AHRQ has been, even though we're relatively young, has been doing a lot in this space. And I didn't include here in the slides, but just for some historical information is, especially during the first Trump administration, is our AHRQ's Evidence-Based Practice Center was doing a lot of reports as well as developing research protocols around the areas of Alzheimer's disease, related dementia, looking at the treatment of Alzheimer's disease, and as well as how can we help improve caregivers. And so some of those systematic reviews were published around 2019, 2020. And one of the things you would find in there, and especially given how rapidly and quickly evidence is starting to change, is some of the evidence wasn't strong or it was low because we're still rapidly assessing and gathering data. And so some of the things you would see in there may be an I grade, so insufficient evidence at the time. And obviously these are things that moving forward we'll probably start re-looking at again because of the amount of evidence that is really starting to hit and would be of benefit of AHRQ to perhaps go back and take a look at those items. So more recently, some of the work that we've been doing, and started with my colleague I mentioned, Dr. Arlene Bierman, is supporting person-centered care for people with multiple chronic conditions. This initiative supported the goals of NAPA by advancing person-centered care for individuals with multiple chronic conditions, including those living with Alzheimer's disease and related dementias. And through AHRQ's Action for Network, we were identifying practical, evidence-based strategies to integrate person-centered care planning into routine clinical practice. And the work engaged experts, partners, frontline stakeholders, and it culminated into an action plan to support national implementation and scale. So what this slide does is it's going to summarize some of the key findings that came from this Action for Learning community on person-centered care planning. Some of the key things participants emphasized was that PCCP supports progress across the quintuple aim, including improving patient experience while supporting clinician well-being. At the same time, implementation barriers are real, time constraints, particularly for care team members, along with funding mechanisms, measurement challenges, training needs, and transformation fatigue were consistently identified. Successful implementation depends on leadership and clinician buy-in, supported by a compelling business case and real-world examples. Teams highlighted the importance of coordinating training, enabling by partnerships with professional organizations, as well as digital tools to support information sharing and care coordination. Addressing patients' health-related social needs through community partnerships and applying implementation science methods to fit the PCCP to specific clinical contexts were also identified as critical strategies. I have the link here if you want to read more into that report and the findings. But my big takeaway, and as we're all here and we all realize, it takes a village to do a lot of this work. This slide takes a look at some of the work that comes from out of my team shop, our Division for Digital Healthcare Research. And we're looking to help advance NAPA goals through the use of digital health innovations that promote healthy aging and reduce risk factors associated with Alzheimer's disease and related dementias. In 2025, ARC convened a national webinar highlighting ARC-funded research focused on digital solutions for aging populations. Presenters showcased tools designed specifically for older adults, telehealth approaches that improve adherence and self-management, and platforms that integrate patient-generated data in the clinical workflows. Together, these strategies strengthen system-level capacity to support risk reduction, chronic condition management, and overall well-being among older adults and their caregivers. I will also highlight one of the projects for this was Lab Genie, which is out of Florida State University, Dr. Z. He, and he was looking at artificial intelligence and particularly the use of large language models to support both older adults and their caregivers when they get lab results to not only hopefully help them understand the results, but also to define what questions should they be asking their clinician when they go for follow-up. So we've been doing some of the early research in the large language model space around generative AI. And there's a link there to the webinar. As I mentioned, ARC had done some earlier evidence reviews, and we're doing some more. And so in 2025, ARC's Evidence-Based Practice Center program completed a peer-reviewed draft systematic review focused on improving the management of menopausal symptoms in perimenopausal and early postmenopausal women. The review was developed to inform an NIH Pathways to Prevention workshop and examine the benefits and harms of pharmacological treatments, including outcomes related to Alzheimer's disease and other dementias. To date, the authors found no evidence of harm from these treatments with respect to Alzheimer's disease or cognitive decline. Some of the other work that we have going on at AHRQ is ARC-supported research that advances the management of chronic conditions among people living with Alzheimer's disease and related dementias. Investigators identified seasonal patterns in metabolic and immune biomarkers with variations across age and gender. These findings help clinicians more accurately interpret laboratory results and respond to physiological changes in this population. By improving diagnostic accuracy and chronic disease management, this work contributes to higher quality and more efficient care for people living with dementia, supporting the goals of NAPA. And coming here, I think, on the last slide. Our kind of last activity that I'll highlight in support of APA is strengthening the evidence base for care of adults with Down syndrome, a population in which Alzheimer's disease and related dementias are nearly universally prevalent at older ages. ARC is completing a systematic review entitled Medical Care for Adults with Down Syndrome, which evaluates treatments for conditions commonly encountered in adulthood, including ADRD. By rigorously assessing the available evidence, this review will inform updated clinical guidelines and address long-standing gaps in care quality, supporting more accurate diagnosis and improved management for adults with Down syndrome, including those living with dementia. And it is expected that this report will hopefully hit here soon in early 2026. There's my email. If you have any questions, please don't hesitate to email or come up and speak to me later. Thanks.
Thank you so much, Kevin. Before I turn it over to our final federal agency presentation, I'd like to acknowledge our other federal partners who were not able to be here with us today. So the Substance Abuse and Mental Health Services Administration and the Department of Veteran Affairs. And now I will turn things over to Dr. Helen Lamont to present on ASPE.
And I will be quick. So my goal today is to tell you a little bit about ASPE's role in progress, and you think, gosh, ASPE's role is to convene the NAPA FACA. But we do a lot more than that. So ASPE stands for the Assistant Secretary for Planning and Evaluation, and we are the Secretary's policy think tank. So we do a variety of initiatives. We manage cross-departmental activities such as this, but our main bread and butter work is conducting policy research studies. So the goal is to have somebody in ASPE who knows almost everything that's going on in the department or who can find out, and then to be able to answer policy questions. Our office is Behavioral Health, Disability, and Aging Policy, so those are the populations we focus on. In the interest of time, I'm going to just go on. So our approach to our work is to identify emerging problems and policy issues, to figure out what the policy options are to address those issues, to figure out the strengths and weaknesses of each of those options, usually to figure out which one we can do with no funding, and then to come up with key considerations for policymakers. So as you think about all of these challenges that we're thinking about, this is sort of the hat that we wear. I think we've gone in order of descending budget. So our budget is, I think we're about $42 million, $43 million. So we are small but mighty. Most of the research that's being done is being done by the other agencies around the table. So we find little niche issues or places where we can add to the policy discussion by looking at something a little bit smaller or at a slightly nuanced perspective. So just some examples of policy research we've done on Alzheimer's disease and related dementias. We've looked at just holistically what the characteristics are of that population, functional trajectories at the end of life for people with dementia. We'll talk about this in a minute, so I'll just hold there. The implications of alternative methods of identifying people with dementia. What number is right? Is it the number of people who have a diagnosis in their Medicare claims? Is it the number of people who say a doctor has ever told them that they have Alzheimer's disease or related dementia? Or is it the number of people who, based on a neurocognitive test in a survey, show up as having dementia? So we've looked at what the strengths and weaknesses are of all of those different methods, which have important implications for the research that we all do and for the numbers that we use. We've looked at opportunities to bridge healthcare and social services for people living with dementia and their caregivers with ACL, and then the use of inpatient psychiatric facilities by Medicare beneficiaries with dementia. You may not know that sometimes a person with dementia will have such severe behavioral and psychological symptoms that they need to visit an inpatient psychiatric facility, and we want to understand what the needs were of those populations and then what their trajectories were afterwards. So some recent policy research that we just came out with was approaches to dementia care and special needs plans. The guide model just came out of CMS, I guess it was 2024, and the question we kept getting was like, this is great, but it's for fee-for-service, and most Medicare beneficiaries are now in managed care. So this project looked at what special needs plans, which are a specific type of managed care plan, are doing to address dementia care. So I suggest you take a look at that. And then alluding to those trajectories of people with dementia at the end of life, we looked again at what hospice use patterns are for people with Alzheimer's disease or related dementias. So as you all know, people with dementia have a long, slow decline often as compared to people with other terminal diagnoses that have a more rapid decline. But we have one hospice benefit, and it is made for a very specific type of prognosis. And so we have some work in that area to look at whether and how the hospice benefit meets the needs of people living with dementia. So that's an example of the type of niche policy research project we might do. And then because our work is focused on long-term services and supports and behavioral health more broadly, anything that sort of affects the long-term care system is going to affect people living with dementia by and large. So we've looked at different long-term supports and services reform options. We've looked at telehealth in nursing homes, especially during the COVID pandemic, and how well that worked for people. We've looked at state and federal tax credit laws and what the uptake is like, who benefits, et cetera, and then rebalancing Medicaid-funded LTSS. So that's in our LTSS bucket, and then on our behavioral health side, it's important to remember the behavioral health impacts of having dementia and the co-occurrence. So 988 is our crisis service number, and we've looked at what approaches states have taken to meet the needs of people with disabilities, including people with dementia. When someone calls 988 for a person with dementia, the response is and should be different than somebody else. And then looking at behavioral health prevalence, utilization, and spending for older adults on Medicare, many of whom also have dementia. So that's just a little taste of the policy research that we do, and thank you all for being here today.
Thank you, Helen. I couldn't think of any finer people, such smart, amazing experts to get to work with. So it's been a pleasure just to get me up to this space to spend this kind of time with Helen and Maria. So I can't thank you enough for the work of ASPE. So now we get to pivot back to our innovators. So it's changed up we changed up the agenda just a little bit. So now we're going to hear from MMI. So MMI, are you ready? I'm going to tell you a little bit about your presenter today. Mark Toland, who represents MMI as the CEO. MMI is a microsurgical robotics company. Before joining MMI, Mark served as the president and CEO of Corindus, where he transformed the company into the industry leader in vascular robotics with the only approved system for coronary, peripheral, and neurovascular indications, and a next-generation robotic system enabling remote endovascular stroke treatment. The Siemens Healthineers acquisition of Corindus for $1.1 billion was the fifth largest medical technology acquisition of 2019. Prior to Corindus, Mark served as Senior VP of Boston Scientific, where he built the company's global healthcare solutions business and led all aspects of the U.S. commercial team's cardiovascular businesses, which represented approximately $4 billion in revenue. Mark has over 25 years of medical device experience. He's a member of the collaborative cross-industry fast company Impact Council. Mark Toland holds a Bachelor of Science in Business Administration from the University of Louisville, and he resides in Ponte Vedra Beach, just outside Jacksonville, Florida. Please join me in welcoming Mark Toland from MMI.
Thanks, Michelle. Thanks for the whole council for having us here today. It's a great honor to be here presenting our technology in front of you. I will not show robots here today. I'll kind of show more concepts. Following Helen's presentation, I thought was a great theme because she was talking about her budget. Well, our budget is zero, so it falling in the theme of zero for us right now. So we're a privately funded company that is kind of falling into this world that we live in, which is in the neurodegenerative space. So let me quickly introduce myself. As Michelle mentioned, I'm the CEO of MMI. We've been developing technologies in healthcare, really themed around a general concept of do things that a human can't do. And so a lot of the companies that we've started up, and most of these are all startups, we have kept to that theme. So the current technology that I'm talking to you about here today resides in Florida. It's called MMI, and it's doing things surgically that was thought impossible to be done by humans, doing things at a scaling feature of sub 1 millimeter. Think of it like sewing the human hair together, about the size of your eyelash underneath a microscope. So very difficult to do, but it opens up, once the technology is available, and it opens up the whole field of surgery that was almost impossible for a surgeon to do. All the other companies are all in the medical device space and are doing various other things that I sit on boards of. So the journey here today is a plumbing problem. So as we kind of think about the lymphatic system, when we are typically working on things that have to deal with life-saving events like the arteries and the veins of your body, you naturally think of heart attacks, like let's go fix those so that it saves my life. Well, the lymphatic system is actually a quality of life journey. So as you think about repairing the lymphatic system, it happens in all shapes and sizes. It's just not for what we're going to talk about here today. It even happens with athletes, and I'm probably the only person that's presenting LeBron James here today. But the point is that it is a system in all of our bodies that is doing things for us that oftentimes go unnoticed, but it heals the body. It allows us to remove toxins from certain parts of the body so that the body can then recover itself. And it happens with athletes who go through a series of extreme events, such as LeBron James, who has the Normatec system on his legs after he plays basketball. And what we're going to talk about here today is a similar concept, but instead of it happening in your legs, it's really happening in your brain. So you can't put a Normatec on your brain to restore lymphatic fluid up there. And it was really an interesting journey for us in science because the lymphatic system was just recently discovered in the brain only 10 years ago. Only 10 years ago. You think about modern science. That's really hard to believe. But it was discovered about 10 years ago, and since then there's a lot of interest in what does the lymphatic system do to help the brain recover? And a lot of physicians that you talk to will say the lymphatic system at a healthy standard is like sleep on steroids. So it really allows your brain to flush itself. And over the course of the last 10 years, we didn't really develop the platform to go after Alzheimer's surgery. We developed a platform to do surgery that couldn't be done by humans. And the reason we got involved in it is because the science that we discovered was very interesting in this space, because our technology helps surgeons do this procedure more precisely and easier, and allowed them to do the procedure that they previously weren't doing before. So as a result, our journey has been kind of falling into it, learning along the way. And so as we thought about this, particularly as the brain recovers, the one thing that was missing was just a good body of scientific evidence that would support a restored lymphatic system that could support doing Alzheimer's surgery. And so what I'm going to talk to you about here today is doing Alzheimer's surgery for the lymphatic system, that you reconnect it back into the venous system so that it restores the flow in the brain of a healthier lymphatic flow than it previously existed before. And so the concept here is, does the lymphatic system clean the brain before you treat the brain? And we don't really know the answer to that yet, but all signals are kind of pointing us in a positive direction to say, let's go explore this, and let's really understand what's happening, who's it happening to, and how can we treat them differently. And so what we did as a company, we are, like I mentioned, just a robotic company enabling surgery to be done better and more precisely. We really explored this over in areas of the world that this was happening. The number one place it was happening was over in Asia. So we spent the last 3 or 4 years really studying the procedure. And there was very little scientific rigor behind it. As a result, having dealt with medical technology for many years, evidence is the key to ensuring that this ends up happening in something in the patient care realm. So the evidence just wasn't rich enough. And so as a result, we started to build these clinical trials. Here's one in South Korea. And I'm going to get to the punchline here in a second, but the early data in South Korea is pointing us into really an exciting time of what this potentially could mean. And is this really going out and curing Alzheimer's? No. Is it potentially delaying them? Maybe. Is it potentially moving a patient from moderate to mild? Well, that's what we've just shown in a series of 6 patients in South Korea. By doing this procedure for moderate patients with Alzheimer's, we've moved their MoCA score back to mild, so that then now they can be treated with a drug therapy regimen, where previously they fell off the drug therapy regimen. Really remarkable. So as a result, we approached the FDA last year. We said, look, we can go do this clinical trial. We're a global company. We can do it in Korea. We can do it in Japan. We can do it in China. But would you consider doing it on U.S. soil? Would you consider doing this trial in the U.S.? And the FDA looked at us and said, yes, we would. So they granted us an early feasibility study trial called REMIND in August of last year. And this is an exciting time for us, because we're embarking on this journey of trying to bring evidence to a surgical option for patients who are suffering from mild or moderate Alzheimer's. Our trial is going to start in a matter of weeks. So the protocols have already gone through all the IRBs. The physicians are already trained. They're currently screening patients for this trial right now, and people will be enrolled in the trial for a surgical Alzheimer's treatment that suffer from mild or moderate Alzheimer's. Think of it like clean the brain before you treat the brain. That's the concept behind it. We're embarking on that top level right there, which is our first 15 patients. It's an EFS study, early feasibility study. If this shows that it's safe and effective, we'll then move into a pivotal trial that'll start later this year. These are the current sites that are currently participating in the trial. You can see we've got Baptist Health, which is in Florida. We've got Stanford, which I think everybody knows is in Palo Alto. Jacobs Institute is in Buffalo, New York, one of the great neuroscience programs in the United States. And we've got Yale, New Haven, Connecticut that's participating in the trial. These are the first 4 sites that will be enrolling in the trial and about 15 patients. So my quick, easy presentation is I'm really impressed that the FDA granted us this IDE, allowing us to really do a multi-center, rigorous trial to go prove this has patient benefit. That's an exciting time for everybody in the United States, but definitely for us as a company, because we're pioneering something with the agency on what could be for patients. Based upon what we've seen in Asia so far, we're pretty confident this is going to work. So we're really excited about it. Our next step with the federal government will be, okay, well, how do we get this funded? This is going to be an expensive trial. It's an exploratory trial. It costs around $75,000 per patient to enroll. We have to go find that funding. That's expensive. So we'll continue to be trying to find ways to see if there's additional funding out there for us to support accelerating the science behind this surgical treatment option. And then finally, as we continue to grow the evidence to support this particular application, we want to work with CMS, the FDA, and NIH to come up with a package that allows patients to benefit from this as soon as they possibly can, giving them a potential alternative to an option where they may not have had one. And who knows where this could go? This could be going into the path of prophylactic treatment for patients who have Alzheimer's in their family tree. But we're just on the early stages of the journey, and thanks to the council for listening to us. Thanks for the support that's come from already the U.S. government. Doing this powerful research in the United States is going to make this real or potentially not real. You never know about medicine. But what we like is the fact that these centers that we all trust and know are behind it. They're supporting it. And we've got a multidisciplinary approach that includes surgeons and neurology and neuroscience, helping to look deeper and closer at this option to potentially help patients who are suffering from this tragic disease. Thank you.
Do we have any questions from the audience for Mark? Okay. Mark, I just wanted to thank you and MMI. Between Dr. Bateman and Mark Tolan with MMI, I hope that you are getting your hair blown back just a little bit on the research, and you're getting really excited about not only regular approaches that we see in pharma, but also novel approaches that are non-pharma. So I can only think of something like that coupled with pharma and where we could go. So it's just, to me, thank you, Mark. Thank you to MMI for being here today. And again, thank you to Dr. Bateman, who left, but just to see 2 different types of research that we got to experience today is nothing short of amazing. So it's a thrill to hear about this. Like I said, we're going to continue to advance the research and work as a council to take all the obstacles out of the way and make sure there's plenty of runway for amazing research and keep that pipeline robust while we're taking care of families that are living with Alzheimer's today. So thank you again, MMI, and thank you for our innovators. We'll continue to host innovators throughout the year in different parts of our quarterly meetings. So thank you.
Okay, sorry, it's me again. Staying between us and the end of the day. So what we wanted to finish with was getting your input. I know a lot of people have been sitting around today just listening, and we did not bring you here today just to listen. So we want to get your input, although it's mostly on the logistical part of this. So there's been a lot for you to take in. We definitely want your content and expertise. But one of our first most pressing issues is revisiting the national plan. So we won't go through this whole thing except to draw your attention to goal number 1. And it says prevent and effectively treat Alzheimer's disease by 2025. Unfortunately, we're not going to reach that goal. And so we do love these goals. We all know these goals, me probably more than anybody else. But it feels disingenuous to just cross out 2025 and write 2035, as if nothing else in the world has changed. And so we see this coming year as a big opportunity and a big job to revisit this national plan, and it's very important to us and to the Secretary and to everyone in the administration that we get input from you all and from members of the public on how to do that. So I'm not going to go through the whole thing, but we're thinking about what approach we should take, how to engage the public through a request for information and/or listening sessions, definitely through the advisory council. And then our goal is to develop a framework and build out, similar to what we currently have, goals and strategies that align with HHS priorities, but that set ambitious goals for us. I will say when we put in the 2025 goal, I mean, you can ask Dr. Hodes later what he thought about that. We were like so ambitious, but it was so important to the field for us to do that. So how can we set a genuine ambitious goal towards 2035, and how do we get there to do that work? And our goal is, the 2025 update is coming out soon, but we need to do all of this in 2026 so that we can meet our statutory requirements to update the national plan in 2026. So we want to set a vision for the next decade. We want to reflect the world, the people around the table, and then what's going on out in our communities. We do want to update our goals and maybe change them, but we have a lot of questions, like do we streamline or expand the national plan? We've been asked both, is there a shorter, sweeter document than the 170-plus page national plan that's an accounting of everything? And we've been asked, is this everything the federal government is doing? And actually the answer to that is no. That's just a snapshot of what we're doing on very specific activities related to Alzheimer's disease. And so we want to hear from you all and from the field, what are you looking for? What do you want from your federal government when it comes to this national plan? Because we could go either way. It'd be hard to do both without an appropriation, but we could go either way. And so what are we looking for? The other thing we used to say in the beginning was that it was a national plan and not a federal plan, and unfortunately that's not how it's actually played out over time. We've had a number of challenges and have tried through the years to reflect what's happening in the private sector or at the state and the local levels. So if you have thoughts on how we could do that and if we should do it, we would really love to hear those thoughts. I think during the time when they tried to do that, I had taken a step back from NAPA, but we just put out a call for information. And so we included information on what, I think it was some localities were doing or some private sector folks were doing, but it was only those who had stepped in and volunteered that information. And is that really a genuine reflection of what is happening? Does it matter? Is it that helpful? We would love to hear more about what folks think about that. And then the other thing I didn't put on this slide, but Amy reminded me of today, is that only 6% of people who die with dementia have Alzheimer's disease only. So that means 94% of them, if we find a magic bullet for Alzheimer's disease today, we will still not have addressed dementia for 94% of people. So how can we reflect that in our national plan? Do we change the language that we use? Do we specifically call out related dementias? Because I think we can all agree that even if we were able to find a cure for Alzheimer's disease tomorrow, we would still have a ton of work to do on the related dementias. So how do we reflect that in our work? Because the nomenclature is very, very important. Another place we'd like to get your thoughts is this is a rough graphic of how the goals overlap with the disease trajectory. So along the bottom, you'll see from pre-symptomatic to symptom onset to mild, moderate, and severe dementia. And when we added the 6th goal, we thought this was useful to show where the goals fit on that life course perspective for dementia. One idea is to take it from pre-symptomatic and to think about our goals from pre-symptomatic through end of life and then the cross-cutting goals. So that's one possible approach. But as we've broadened out the populations that we are targeting through our work, how should we reorganize and rethink about that? And I think that's it. That was enough. So there's a lot to think about. We would love your thoughts. It is 4:11. You don't have to tell us anything. But if anyone has done this in other parts of your life, in other work, or if you just have some principles that you think would be helpful for us to consider
Helen,
as we go forward,
you know,
we'd love to.
I just wanted to say it's incredibly humbling to me. Well, everyone's presentations today, amazing, enlightening. It's humbling to be here. Just wanted to say, you know, Helen, we spoke about this when we initially met. And I just want to talk to Michelle for a quick second as the chair of this council. A lot of people define themselves by their job and their role. They define themselves that way. They introduce. I don't think you're defined by the chair of this council. I know you for a long time, your passion, the strength, and your power to knock down barriers. I think you will define the role. And under your leadership, I am greatly optimistic that we're going to make a lot of change. When COVID hit in 2020, in March, President Donald Trump, I think, showed us a formula that worked. Within 2 months, we had all the ventilators we need. We were exporting ventilators around the world. Within 3 to 4 months, we had all the tests you wanted. You were getting 5 tests a day, whatever you wanted, all these different tests. By 8 to 9 months, we had therapeutics and FDA-approved vaccines, numbers of them. The greatest pandemic the world has ever seen in our lifetime was solved. We're sitting here together. No one's wearing a mask. We're not 6 feet apart. We're traveling. That type of mentality, if we apply it here, would make a great impact. I've heard of tens of billions of dollars that we're spending on research, tens of billions in all these different sectors, and just a handful of things trickling through the FDA that are reaching people. How is that possible? What the president showed us was how to put the pieces together in the proper balance. Where does the FDA fit? How does capital come in? How do we unlock the engine of innovation from industry in order to solve these problems? And I'm incredibly optimistic that we'll be able to deliver some concepts and ideas that will be able to be brought to Secretary Kennedy and Congress. As you said, this council reports to both. So thank you for your leadership. I look forward to being part of it.
Hey, Helen, I think that your comments are spot on. I completely agree with what you just said, but and it was very well said, I might add, but just to bring it down specific to the goals for a second, I too am incredibly impressed. The quality of I'm not surprised by this, I've said it to my 2 colleagues to the left and right of me, the quality of the federal government employees and executives around the table is outstanding. I mean, I'm not surprised by that because I've worked with the federal government a very long time, but it's kind of nice to see it in action in a different capacity. Outstanding work. And the resources we have around this issue is incredible. Communicating it to the broader base and to the country and connecting the dots for people to say, look at everything we have available is, I think, should be considered as a goal. And I think that if we could figure it out in very practical terms, we might even be a model for other advisory groups. And I think that could be scalable, a communication plan and sort of breaking down silos, applying some systems thinking, doing some things in a very practical way that kind of moves the ball. And speaking about sort of moving the ball, one thing you might want to consider when setting goals, we do this in private industry all the time. We love setting big, hairy, audacious goals. That's important. But we frame it in a way of like stretch target threshold. Now, I'm going to speak very practically for a moment, because what we don't want to do is unintentionally demoralize the team when they're chasing after something and making incremental improvements and making a difference. But the fact that we didn't achieve the 2025, like we're going to solve Alzheimer's, I mean, that's a big, hairy, audacious goal. And that should be there. People should strive for that. But there should be a target and a threshold so when teams do achieve success, they do make a difference in the lives of patients and families and caregivers. They can see it through a threshold and target goal. And that actually becomes a motivator to drive even harder and faster to that big goal of solving Alzheimer's and dementia and related diseases. And so I think give some consideration to that. I mean, obviously, I'm excited to be here and happy to roll up my sleeves alongside the whole team and be part of it. But you might want to think about it in terms like that. It can be very motivating for people as it's all about incremental improvement, right? It's always about going this way in achieving your goals and your desired outcomes. You've got to incent people and get people excited along the way and build them up. And I think you have a great opportunity to do that because the work that's already been done is extraordinary. It's something to think about.
I love both of these comments. They're so helpful. And I think, Helen, to your point earlier, in looking at the disease pre-symptoms, so really taking the time to look at root cause, pre-symptomatic pieces. So, and that goes back to, right before early detection, early diagnosis, risk reduction, things like that. I want to make sure that we're capturing that. So if you all are okay with that, I think what might be a healthy discussion is take all the notes from the members, get all of the input here, and then Helen and Maria and I can and we can work with Kate and just sort of synthesize all of that, come back to you with some really good goals that I think are more reflective of where we are today. Does that sound? Because I know we have our thoughts, but I'm loving hearing from the council too, as you saw all of the agencies present and where we are today with the research and the support services and the care, what you think our next order of business is. Anyone else? This is really good feedback. Don't make me start assigning you subcommittees, because that's where we're heading next. Yeah. We've spent a lot of time today digesting, which I think has been incredibly important. And like John and Jonathan, I hope that you felt really reassured, as I've said before, that your federal government is plugged in, that your Secretary of HHS is plugged in. I've said it several times that he is the first secretary I've ever heard of mention Alzheimer's on the Hill. Not once, not twice, not 3 times, but 4 or 5 times. That he has got innovations. There's an innovation program that Mary and I were talking about too, about caregiving. So there is so much out there, and we have leadership at the very highest levels that are spotlighting this important disease. So when I first began, all we could say is, sorry. There's no prevention, there's no treatment, there's no cure. And all I could do is stand next to families like Steve and Gina Waterhouse and say, I'm here to work on the future, but I'm so sorry about this present. But we have a different present happening now. Is there anything you wanted to say, sir? Oh, your mic.
Sorry, when we started this journey, Gina made a cape that said first survivor of Alzheimer's, and she wore it to all of the Alzheimer's events. And she slowly started to realize she wasn't going to be. But I think at the end of today, we're starting to realize we might know that person. We might know it in your lifetime. We're close. Thank you.
Michelle, I want to echo what everyone else has said, and particularly my colleague John Corus. For us that are in the operational field of getting this work done, what I'm most impressed with is there's attention not only to finding cures and remissible opportunities, but we're focusing on how to help families and individuals like Steve help their family members, because education of families and caring for folks going through this is monumentally important. It's one thing to have these advances. I'm excited about this surgery opportunity and Dr. Bateman's work as well, but educating families to take better care of both themselves and their ability to take care of their family members is so very important. So I don't want this committee not forget that as well, because I think a bigger picture behind what the Secretary is doing is a healthier community throughout our country, and we've got to promote and encourage people to take better care of themselves, and we may start that right here in this work as well. So thank you for your leadership.
Thank you, sir, and thank you, Steve. Anyone else? Dr. Handel?
I just don't, you stole my line, Michael. I think the concept of unmet clinical need, hearing that from Steve and Gina, it's here. We don't have 10 years, guys. This has to happen in 5. Again, and every time I'm in front of the FDA, I tell people that I have the utmost respect, because as agencies, you advocate against possible risk exposure to our patient population. As physicians, we do the same. But I think we gotta find a way that we can work together to make this faster. And it's phenomenal to hear Dr. Bateman talk about AI. Again, we gotta find better ways than 2 years of an animal implant waiting for that device to mature, where maybe in Europe we have treated 1,000 patients, 2,000 patients. We gotta find a way to organize this data. It was beautiful to hear somebody from the HHS today talking about how can we integrate all these systems to harness this data and do this faster. We gotta do this better. And I think, me too, I am inspired to see the power that we have on the federal government. Hats off to you guys, because the backbone is here. And I think stepping on what you guys have here, I think we can do this better for every single one of our citizens. And that, I think, is our goal here. Everybody that comes through the door here wants that, to do what is best for your mother, your father, your sister, and those that suffer through those diseases. So I'm honored to be here and serve side by side with you guys. I think with the brains in this room, I think we can make a huge impact. Thank you for the opportunity.
I think you hit a very important point. It's about risk. The federal government or the FDA is not built to take on risk. I mean, industry typically takes on risk, and there's a certain comfort level around that. And you can't blame somebody for saying, you know what? No, give me 2 more years of data, right? Because how are they gonna justify that when they go home? And just too much risk for. So I think perhaps building into our goals is to explore how to de-risk some of these agencies where there is room to try, or the right to try, where there's a signal, enough signal. What is enough signal?
Thank you. And we've got one more comment before we have to go to public discussion. So, Christy?
And I think just building on that, the signal, representing state leadership and having been Secretary of Human Services, you know, I think the state policy level can partner very closely with the federal level, and we can inform when is the time. You know, we can bring to you all, Patients' Right to Try is a great example. That is being discussed in several states who really want that as an option for patients with Alzheimer's and beyond, obviously. You know, I think the really critical thing that I'm hearing around the room is we have all these resources that may or may not be connected. I have a saying that I use all the time. It's people don't come to us in pieces, and yet we are planned to budget and plan for them as if they do. And so I'm very encouraged by what I'm hearing here about bringing it all together, connecting the pieces, and us trying to help from the state and local level with what kinds of policy changes are being demanded in the operational space, in the field, that we can help bring to the federal level and bring it together. So thank you all very much. It's an honor to be here.
Thank you. Thank you so much.
All right, we are now going to turn to public comments. I think we're going to start with the folks here in the room with us. There's a microphone in the back of the room, so please feel free to walk up when your name is called. First up, we have Dr. Lisa McGuire from the Gerontological Society of America. Good to see you, Lisa.
All right, good afternoon and thank you for your time today. I'm Dr. Lisa McGuire, Vice President of Strategic Alliances and Practice Innovation at the Gerontological Society, or GSA. Many of you know me. I am a former NAPA Advisory Council member, and I held CDC seat for about 20, not 20 years. I was with CDC for 20 years, but I held the seat for almost 10 years, and I just retired in 2024 after 20 years of federal service. So, not about my history now, but let's talk about what GSA does and the important role the Advisory Council does. So our mission at GSA is to cultivate excellence in interdisciplinary research and to advance innovations in both policy and practice. GSA has over 6,000 members who are gerontologists, health professionals, behavioral and social scientists, biologists, demographers, economists, and many other disciplines. We actually have 26 different disciplines of gerontologists as our members. They're experts in all different facets of aging with a life course orientation. The multidisciplinary nature of GSA's membership is really our valued strength, enabling the society to provide a 360-degree perspective on issues of aging and the population as we are all aging. GSA advances major initiatives related to early detection of cognitive impairment, improving oral, hearing, and vision health, framing our language to improve public's understanding of aging, and understanding the impact of longevity and the economy. Our flagship activity addressing brain health at GSA is the GSA CARE Toolkit for Brain Health. CARE is K-A-E-R, and I'll tell you about that in a minute. This toolkit is intended to support primary care teams in implementing a comprehensive, interprofessional, person-centered approach to initiating conversations about brain health, detecting and diagnosing dementia, and providing individuals with community-based support. It includes practical approaches, educational resources, and validated clinical tools that teams can integrate into their workflows. While the contents and selection of the tools were developed with primary care teams as the principal audience, others, including educators and students in disciplines such as medicine, nursing, and social work, have found the contents useful. Through our podcast that include members of expert advisory panels and other key opinion leaders, these podcasts share with you how you can use the CARE framework. So let's tell you what CARE is. So K is for kickstart. Kickstart a brain health conversation. A is for assess. Assess for cognitive impairment. E is for evaluate. So evaluate for dementia. And R is to refer to community services. We invite you to learn more by visiting our website at carebrain.org. So it's K-A-E-R brain.org. We want to thank the Advisory Council for their continued commitment to convening regularly and guiding the nation's response to Alzheimer's disease and related dementias. Your work is essential not only to the national plan's progress, but also to ensure that our country responds to dementia in ways that uphold dignity, strengths, and contributions for all of us as we age. By meeting consistently and engaging diverse expertise, the Advisory Council helps ensure the federal agency efforts remain coordinated, person-centered, and responsive to the needs of people living with dementia and their families. Through, they let me by myself, see what happens? Thank you all of the members of the Council for your steadfast service, your leadership, and your commitment to ensuring that millions of Americans affected by Alzheimer's disease and related dementias, and the millions more people who are providing care and support for them, receive the evidence-informed, respectful, and person-centered support they deserve. On behalf of GSA, we look forward to continuing to work with you.
Thank you. Next up, we have Sean Feely from the National Down Syndrome Society.
Good afternoon, everyone. My name is Sean Feely. I am the Director of Advocacy and Public Policy at the National Down Syndrome Society, or NDSS. We are grateful for the opportunity to provide comments today on the unique impact of Alzheimer's disease on individuals with Down syndrome and the need to include this community in the work of this council. Down syndrome occurs when an individual has a third copy of chromosome 21 instead of the typical 2. Chromosome 21 also carries genes which are strongly associated with the formation of amyloid peptides and plaques that are a hallmark of Alzheimer's disease. In fact, individuals with Down syndrome have a higher than 90% lifetime risk for developing Alzheimer's, and the disease is the #1 cause of death for adults with Down syndrome. The average age of onset is lower, and the disease also progresses faster than in the general population. Simply put, Alzheimer's disease has a devastating and disproportionate impact on the Down syndrome community. While historically individuals with Down syndrome have been underrepresented with respect to Alzheimer's disease conversations, clinical trials, coverage determinations, and other efforts, change is underway. NDSS is grateful to this council for finalizing recommendations in September 2024 that reflected an unprecedented inclusion of the Down syndrome community. NDSS was also proud to work with Congress on the NAPA Reauthorization Act, which created a new seat on the council to represent a population with an elevated lifetime risk of Alzheimer's and made explicit reference to the Down syndrome community. We strongly recommend that a representative of the Down syndrome community be included on this council. We support the vital work and mission of this council and urge you to continue the important focus on the Down syndrome community's unique needs related to Alzheimer's disease research, education, diagnosis, clinical care, caregiving, and more. NDSS stands ready to work with you to foster transformational change for the Down syndrome community. Thank you.
Thank you so much, Sean. Next up, we'll have Dr. Diana Zuckerman from the National Center for Health Research. Dr. Zuckerman, are you here?
Yes, I am. Can you hear me?
Oh, yes.
I tried to make myself visible, but no such luck. I'm Dr. Diana Zuckerman, president of the National Center for Health Research. Our nonprofit research center does not accept funding from entities that have a financial interest in our work. And I hope that you'll include some of these two issues that I'm going to talk about today pertaining to research and federal policy. And of course, thank you so much for serving on this important council. Number one, we strongly support Medicare's requirement for registries for patients taking anti-amyloid drugs. As we all know, they have serious risks as well as evidence of benefits, and we need to know whether the benefits outweigh the risks in the real world and for which patients. And also, since there are two such drugs, we need to know how they compare to each other. Unfortunately, the registries that are run by private entities under CMS rules are not required to provide detailed data to any agencies in HHS or any other independent researchers. They're only required to provide a summary of results similar to a medical journal article, and that may not include all the kinds of information that patients, family members, and physicians need to make informed choices. It's been 2.5 years, and the results haven't been published in a peer-reviewed journal, and only summary results from the AltsNet registry have been made public, and they don't compare the two different kinds of treatments. In fact, they even include Aduhelm, a drug that's no longer available. So I hope this advisory council will require that detailed data will be compared and will be analyzed by CMS or NIH and be made publicly available this year. For number two, we're very concerned about evidence that Alzheimer's patients and other dementia patients are often given atypical antipsychotic medications such as Seroquel or Rexulti even though one well-established side effect is sudden death. And of course, there are other side effects as well. CMS and other experts have attempted to reduce the inappropriate use of these drugs, especially in nursing homes, because of their risks. But misuse continues, and everyone agrees that it's gotten out of control, and there's some new research on that issue. Warnings about SSRIs pales in comparison to the danger of atypical antipsychotics for vulnerable dementia patients. Most of these drugs are used off-label, but FDA has approved Rexulti for dementia patients with behavior problems despite these concerns. So I hope that you will look into this issue and work with others on this council to figure out what can be done to reduce this problem. Thank you very much, and thank you for your work, and I'd be happy to answer any questions.
Thank you. Next, we will go to Erica Sword with the Us Against Alzheimer's. Oh, okay. Next, we will go to Matthew Janicki. I hope I'm pronouncing that correctly, from the National Task Group on Intellectual Disabilities and Dementia Practices.
Thank you. You did well with my name. My name is Matthew Janicki. I'm an associate research professor at the Institute for Disability and Human Development at the University of Illinois Chicago, and the co-president of the National Task Group on Intellectual Disabilities and Dementia Practices. We call it the NTG, an organization advocating nationally for adults with intellectual disabilities living with dementia and their families, and also a former member of this council. I appreciate this opportunity to speak to you, and as you prepare to develop the 2026 update of the national plan. The NTG would like to express its appreciation for the council's long-standing commitment to including issues affecting people with intellectual disabilities in the national plan. As research and care practices have evolved, so too have complexities of supporting this population. With that in mind, I'd like to highlight 3 priorities we believe are essential to assuring that the national plan strategies are fully inclusive of people with neuroatypical conditions such as intellectual disabilities. First, we urge the Council to advance diagnostic competencies for dementia in people with Down syndrome and other intellectual disabilities. Adults with Down syndrome have a biologically elevated lifetime risk for Alzheimer's disease because trisomy 21 results in overexpression of amyloid-related genes, leading to earlier neuropathological changes that are seen in the general population. Dementia in this group often presents atypically with early behavioral and functional decline rather than memory loss alone. Yet many clinicians receive limited training in distinguishing dementia-related changes from lifelong cognitive differences, contributing to delayed or inaccurate diagnoses. Recommendations that strengthen national clinical guidance, workforce education, and the use of specialized diagnostic tools would support earlier person-centered identification and care planning for dementia, and improving health outcomes for a population that is growing in both size and longevity. Second, we ask the Council to promote the systematic inclusion of adults with Down syndrome in Alzheimer's clinical trials and treatment studies. Individuals with Down syndrome represent one of the most genetically informative populations for Alzheimer's disease research and are increasingly central to understanding disease mechanisms and therapeutic response. Despite this, adults with Down syndrome and other intellectual disabilities remain markedly underrepresented in clinical trials due to structural barriers, inaccessible study designs, and limited support for informed consent and participation. This exclusion is particularly consequential as disease-modifying therapies emerge, since safety and efficacy data may not adequately reflect populations at highest risk. Addressing these barriers is both a scientific necessity and an ethical obligation, ensuring that research findings are generalizable and that therapeutic advances equitably benefit those most affected. We ask that the Council explicitly include this consideration in the research section of the National Plan Update. Third, we encourage greater attention to Medicare beneficiaries living with both dementia and intellectual disability, particularly through expanded outreach within the CMS guide model and related federal care coordinated initiatives. Through our recent efforts to support increased participation of beneficiaries with intellectual disabilities and guide programs nationwide, we have observed that many individuals and their caregivers fall between aging and disability service systems, often resulting in fragmented care, limited navigation support, and unmet needs. This gap is often driven by limited awareness among guide providers of how dementia presents in people with neuroatypical conditions. Including strategies in the national plan to strengthen outreach, education, and partnerships between guide programs and the disability service networks would improve care coordination, caregiver support, and access to dementia-capable community services for this underserved population. Together, these priorities reflect a shared goal, that is ensuring that people with intellectual disabilities are fully included in Alzheimer's research, care, and support systems. We appreciate what the Council has accomplished to date and look forward to your continued leadership and commitment to equitable inclusion of people with neuroatypical conditions in the plan strategies and recommendations. Thank you.
Thank you, Dr. Janicki. Now we will turn to Ian Kramer with the LEAD Coalition.
Good afternoon and nearly good evening. I'm Ian Kramer. I'm Executive Director of the LEAD Coalition. We are the uniting voice of over 260 member and allied organizations working on Alzheimer's disease and related disorders, and we try to be everything to everyone, and 260 members and allies helps us do that. So we are interested in, as the Council is, in risk reduction, detection and diagnosis, improved quality of life for people living with cognitive impairment, and all the people in their ecosystem, both professional and lay people in their ecosystem, making sure we're looking after everybody who is affected by dementia, not just those who wear the label of dementia. Part of that is the research ecosystem. And as Dr. Hodes and others have, I think, described better than I ever could, research is not limited to what happens on the bench to develop a drug. It is everything that affects quality of life for people at risk for and living with these conditions. So the epidemiological research, the risk reduction research, the curative research, the improvement in the safety and efficacy of therapeutics to address the profound behavioral symptoms that often accompany, but do not always accompany, Alzheimer's disease and related disorders. All that research matters, and so our coalition cares about that research as much as the practical implications of what the research guides us toward as an advocacy community. I had the opportunity to speak with one of your council members earlier, and we were both very focused in our own families' stories about what our loved ones still could do, and not being blind to what they were losing the ability to do, but focusing on empowering the greatest quality of life by recognizing the can wherever possible, and addressing, but trying to compartmentalize to the extent, again, feasible, what our loved ones no longer could do. I'm a little brother, so I'm going to take an unusual little brother moment and brag on my big brother, not something most of us younger siblings do a whole lot, at least on the boys' side. My older brother is literally a Nobel laureate in economics. He's that smart. I am clearly adopted, but my brother is that smart. My mom and dad were equally brilliant and led him to the career that he achieved Nobel laureate status, but also what that Nobel laureate status was for was doing something that's very important in our faith tradition, living through a principle of tikkun olam, which translates from Hebrew roughly to repair the world. My brother's world of trying to create that better future is around economic development in developing countries, trying to save lives and improve lives of the most vulnerable people on this planet. My father loved nothing more than to hear about my brother's work, but even before the Nobel, he loved hearing about my brother's work and what it was doing to repair the world. Gradually, this brilliant father who raised that son, who could achieve those sort of lofty accolades based on remarkable, brilliant, compassionate work, My father eventually lost the ability to ask my brother any questions about the nature of that work, but he never, thankfully, lost the ability to understand what my brother would volunteer. And my brother had the compassion and the decency and the humanity to lean into what my father could do and not just obsess and mourn over what our father could no longer do. I tell you that story a little bit to brag on my big brother, and mostly to say that as you think about the framework for what your council will achieve over the coming 4 years, and you think about the construct that Helen has asked you to contemplate and design, that in all 6 domains of the existing goals, and any goals you may add, you lean into what can people with cognitive impairment or risk for cognitive impairment do on their own as individuals, but what can we do as a society and through the federal government's power, convening power, and interagency collaborative power do to try to minimize the impediments of what they can no longer do. Try to shrink the list of things they can no longer do. Try to return to them, and this goes to Mr. Weiss's point, empower them as early as possible and as much as possible to regain power over this incredibly brutal disease. I know I'm way past the 2 minutes, and I appreciate your indulgence. I'll just leave you with this. You stand on the shoulders of councils before you, 15 years of councils. Nearly all of those dozens and dozens of previous council members, non-federal members, are still with us. Sadly, several have passed away. But call on them. Learn from their expertise. Learn from what they achieved and how they achieved it. Learn from what they wish they could have achieved and realize they didn't have the systems and the structure to achieve at the time that you may now have at your disposal. Take full advantage of the alumni. Call them out. Bring them in. Ask them to be your partners. Ask all of us in this community to be your partners. I can tell you there are over 260 member and allied organizations at the LEAD Coalition that are ready to be your partners. We will bring you ideas. We ask you to come to us with requests for additional ideas and for partnership in implementing those ideas in true public-private collaboration. Thank you.
Thank you.
Thank you so much, Ian. We will now turn things over to Laura Cohen with the Eli Lilly and Company.
Good afternoon. I'm actually Maureen Jaffa. I'm an Associate Vice President on the Neuroscience Corporate Affairs team at Eli Lilly. And on behalf of Lilly, I want to congratulate the new members of the Advisory Council, including new Chair Branham, on your appointments, and we really thank you for your service and commitment on this council and to the community at large. For more than 35 years, Lilly has remained deeply committed to Alzheimer's disease, leading numerous clinical trials and investing over $11 billion in research. Today, meaningful change for people living with Alzheimer's is within reach. With rapid advances in lifestyle intervention, disease detection, diagnosis, and treatment, we are entering the most promising era the field has ever seen. One of many areas we hope to work closely with the Council on, and one that we think was highlighted here today, is around earlier disease detection and diagnosis. Research indicates that earlier detection and accurate diagnosis contribute to more optimal care plans for patients. Detection and diagnostic tools help get ahead of disease, which provides the opportunity to have better outcomes. In clinical trials for early symptomatic Alzheimer's disease, we've seen better outcomes when patients start treatment in the earlier stages of disease. And patients want to know. We know that nearly 4 in 5 Americans, or 79%, would want to know if they had Alzheimer's disease before symptoms interfere with their daily activities. We applaud the administration for the groundbreaking steps it has already taken to accelerate access to an earlier and more accurate diagnosis, especially with respect to blood tests for early symptomatic Alzheimer's disease, including the first FDA clearance for such a test just last year. Now is the time to accelerate our collective efforts to defeat Alzheimer's disease. We look forward to continuing to work with the NAPA Advisory Council on these important initiatives, and again, congratulate the new chair and the council on their appointments. Thank you.
Thank you. And I believe that concludes everyone that's here in person, so we're going to switch to our folks on Zoom. So Dr. J. Neil Henderson, are you available?
Yes. Good. Malito Chimachukma, Saho Chufa Jonil Henderson, Choctaw, okay. Saying hello to you in Choctaw, and I'm Neil Henderson. I'm a member of the Choctaw Nation of Oklahoma. I am a professor emeritus at the University of Minnesota Medical School in the Department of Family Medicine, Biobehavioral Health. And I want my comments to fall into two parts here. And number one is biological, number two is going to be cultural, and that is sort of the human experience of this condition that we're calling dementia. The biological part is that we are beginning to accumulate signals, and as we heard before, some comments about signals and what are the strength of a signal that then would trigger action. But in this case, it's an interesting one in that with the ApoE4 risk factor, one of my studies, another from the Southeastern tribe, another tribe in the Northeast, and then a recent publication out of the Strongheart study, which is up and down the Central Plains, a longitudinal study, is finding that when the E4 allele appears in one or two copies, it doesn't seem to have the same strength to potentiate increased risk for Alzheimer's as it does in comparison to the Anglo-American population. That suggests to me that there is something there to look at. Could have some really important implications, and possibly understanding that mechanism might be something transferable to all other populations as well. On the cultural side, I want to unfortunately report that the first Americans still operate with a stigmatized status from the perspective of many other people. Why would this be? And I think part of it has to do with poverty. Of all of the population segments we might come up with in this one country, the first Americans as a group have the highest rate of poverty, fully 1/4 of the population. And we might also ask them the question of why would this be? And this is when we begin to understand some cultural factors that apply to first American people. And that is, one, the theft of vast tracts of land. Now, to better understand that, I think many people think of land as their mailing address. That's where their house is, that's where they go to sleep and then go to work the next day, and whatever the address happens to be. Land for the first American population retains a sense of, number one, a food source, a water source, an environment that has been experienced in ways that the subtleties of it lead to continued subsistence and sustainability. And it is something that keeps you alive, and much, much more than a mailing address or a piece of real estate that may be for sale. There's also the forced relocation. We know the Trail of Tears. Everybody seems to know that, and that's real and tragic. But there are many other on your feet walks of relocation, forced relocations over time and into very recent times as well. And some may say, well, this is ancient history, and so we don't really need to rehearse that. Let's just move on. Except that we're better understanding the transmission and sustainability of earlier trauma even in generations before a person in the present, through epigenetic effects, but also through it being sustained due to basic racism foisted onto the other. Well, one of the things to consider in terms of culture is how the individual First Nations member experienced the condition and how their caregivers experience the conditions of being a caregiver. And these things have to do with issues related to belief causation, have to do with the associated then, since I believe this is what causes it, what do I do about it? It has to do with anxieties of, am I going to get this? Why did this happen? And many questions that ultimately have a cosmological foundation. That is, why are we here? What do we do now? What's going to happen after we die? That's cosmology. And many of the cosmological belief systems of First Americans are very different. And if we remember anything about Native life, it's heterogeneity and within group variation. So in understanding dementia in cultural context, the matters of disease causation and what people think should be done about it are things that actually end up being crucially important, not often not even, but nonetheless operationalized. There's lack of information broadly, I believe, about the organic causes of dementia. When we look at people that are acknowledge the term Alzheimer's, but otherwise don't know anything about it until it begins to affect that family. The social determinants or influences of health, another one for which there are some unique properties related to the first Americans. And then last here, the information about the nature of cognitive decline and the many faces that dementias present to a family. I find that the caregivers are often ill-prepared for how to optimize their caregiving strategies for the affected person's well-being. And yet, as an educational target. So we have a biological target with YE4, doesn't seem to have the same power to convert to Alzheimer's disease, and now an educational opportunity. Well, there is the International Association for Indigenous Aging, also known as IA Square, that has a website that is a real hub for information specifically on dementia and the first Americans. And so I appreciate the time to review this, and that this population is aging, has lots of poverty, which worsens everything. And I hope would be something of a special effort made in our direction. Yukoki, thank you.
Thank you so much. And I know we're running up against 5 o'clock here, if we haven't already, well, just a couple more minutes to that. So we do have a few more folks that are online for public comment. I'm just going to ask that we keep it to 2 minutes. And I love all the comments. We appreciate them. The council is really anxious to hear from everyone. So if we don't hear from you today, please feel free to get a hold of Helen or Maria, and we'll make sure to get all of your comments heard. So we'll have about 5 more, 2 minutes each. So I just want to let you know that we're kind of drifting a little past 5. And I know I've kept you here since 10 a.m. this morning, so I do appreciate your patience. Just want to make sure we get through that list. And again, 2 minutes for the public comments. Thank you so much.
All right, next up we have Ansel Dow.
Hi there. Can you hear me okay?
Yes, thank you.
My name is Ansel. I live in Durham, North Carolina. Thank you for having me here today. I'm here to speak about my experience as a member of a family affected by familial genetic frontotemporal dementia. Frontotemporal dementia is not Alzheimer's. It's a related form of dementia, and it can be caused by genetic factors and genetic mutations that run in families. What that means for folks in my community is that folks whose parents are lost to the disease, like my mom, also inherit that gene themselves. So as they're caring for a parent or an aunt or an uncle who's lost to this really painful condition, they're also worrying about their own future. That's the situation that I'm in. I know that in the next 10 years of my life, I'm going to succumb to the same early onset dementia that took my mom from me and has taken several of my aunts and uncles. My request is that the council consider genetic and familial frontotemporal dementia as a really critical piece of the puzzle when you address dementia. These patient populations are often underdiagnosed, don't have the same resources as folks in the Alzheimer's disease population, and we offer some opportunities for really tremendous insight into research and cures that could address all forms of dementia. That's all. Thank you.
Thank you so much. Next up, we have Megan Dickin from the International Association for Indigenous Aging. Megan, are you there? Okay, we're going to move to our next speaker.
I'm here.
Oh,
I'm
you
here.
are? Okay.
I'm here. Yes, sorry. I was having trouble coming off mute. Okay. Aletu, and thank you for the opportunity to speak today. My name is Megan Dickin. I'm an enrolled member of the United Homa Nation of Louisiana, and I am the Tribal Public Health and Aging Senior Associate at the International Association for Indigenous Aging, or IA² for short. As we heard earlier from Dr. Neil Henderson, this devastating disease of Alzheimer's disease and related dementias does not affect all communities equally. For American Indian and Alaska Native communities, the impact of Alzheimer's disease and related dementias is especially profound. We experience higher rates of ADRD as well as chronic diseases, later diagnoses, limited access to specialty care, significant gaps in culturally appropriate dementia education and services. This is where the International Association for Indigenous Aging, IA², plays a critical and irreplaceable role. Through the CDC's Healthy Brain Initiative, IA² is filling a national void. We are the only organization solely focused on advancing brain health, dementia awareness, and culturally grounded responses for Indigenous older adults. Through partnerships with the Alzheimer's Association and Indian Health Service, IA² has reached tribal communities across the country. Continued investment in a resource center dedicated to American Indian and Alaska Native peoples through the CDC Healthy Brain Initiative is not just important, it's essential. With continued funding dedicated to serving Indigenous communities, we can ensure that Indigenous elders are seen and supported while living with dementia. We have partnered with the CDC and the Alzheimer's Association and played a vital role in the creation of the aforementioned roadmap for American Indian and Alaska Native peoples, and we appreciate the CDC for mentioning us for that. We also partnered with the Yale Coach GWEP program, mentioned by Dr. Weiss earlier from HRSA, on adapting the 4Ms framework for American Indian and Alaska Native peoples to be more culturally appropriate. We've received excellent feedback on all our resources, which I will share in my written statement later. And I just want to say, we are grateful that the 2024 National Plan update recognized our work with American Indian and Alaska Native peoples, and we urge you to ensure that the National Plan to address Alzheimer's disease for 2026 through 2035 recognizes the unique needs of Indigenous communities and ensures the continuation of the work of IA² through the Healthy Brain Initiative to support the tribal communities that we serve. Yakuki, thank you.
Thank you. Next, we turn to Matthew Sharp with the Association for Frontotemporal Degeneration.
Good afternoon. Thank you for the opportunity to speak today. I'm the Advocacy Manager for the Association for Frontotemporal Degeneration, or AFTD. AFTD has been engaged with the National Alzheimer's Project since the very early days, and we're glad to see the Council reconvened and look forward to continuing to work with you and federal agencies to advance shared goals for people living with FTD and all dementias. I'd like to take a moment to reintroduce FTD and AFTD to the new Council members. Frontotemporal degeneration is a group of progressive neurodegenerative disorders that primarily affect the frontal and temporal lobes. Unlike Alzheimer's disease, the earliest symptoms are often changes in behavior, personality, or language rather than memory. And FTD is the most common form of dementia in people under age 60. And because it often affects people in the middle of their working or family lives, the impact on people diagnosed and caregivers can be especially devastating. Despite this, FTD is still under-recognized in clinical practice, and one of the biggest challenges families often face is simply getting an accurate diagnosis. On average, it takes around 3.6 years from the first symptoms to receive an FTD diagnosis, with symptoms frequently being misdiagnosed as Alzheimer's or a psychiatric condition. These delays can significantly limit access to appropriate care, support services, clinical trials, and planning resources. AFTD is the nation's leading nonprofit dedicated to improving the lives of people affected by FTD through research, education, and advocacy with a focus on earlier diagnosis, better care, and the development of effective treatments. As blood-based biomarkers for Alzheimer's disease move into clinical use, it's critical that people living with FTD and other non-Alzheimer's dementias are not left behind, and that federal research continues to advance diagnostic markers and treatments across all dementias. AFTD welcomes continued collaboration with this council and federal partners, and look forward to working with you to meaningfully integrate FTD into federal dementia policies and research priorities. Thank you.
Thank you, Matthew. Next, we turn to Jadine Ransdell.
Hi, thank you. I'm a family and disability advocate, and I want to thank you for the opportunity to speak with you and tell you about families who are living with someone with Down syndrome and Alzheimer's. I began my advocacy work about 52 years ago when my son was born with Down syndrome, and 12 years ago I started supporting families who have loved ones with Down syndrome and Alzheimer's after we shared concerns with his neurologist, who, with very little information, decided that it was obvious that he had Alzheimer's because he was nearly 40 and had Down syndrome. While we got an incorrect diagnosis at that time, many of the families that I speak with have shared with me that they don't get a diagnosis even when their loved one is showing some significant signs of decline. That premature diagnosis of Alzheimer's for Matthew left us with little hope for the future. And for the families who got no diagnosis, it means a loss of the appropriate supports and services. So I'm asking you as a council to promote the development and validation of effective tools to accurately diagnose our loved ones. Families have also told me that they have unmet emotional and service support needs. NDSS and the NTG, who you've heard from today, have developed resources and training that can help with the diagnostic issues and assist medical providers to give appropriate health care to our loved ones aging with Down syndrome. Community service providers are able to help our loved ones age in place, have a better quality of life, and be more cost effective for our government. So I'm asking the council to help these organizations to increase awareness of the availability of these training opportunities. Community service providers sometimes fail our loved ones, and while providers may want to serve them, bureaucratic rules and regulations may tie their hands. And in addition, funding streams can create barriers. So my request on that is that the council help to remove obstacles by encouraging federal and state governments to allow collaboration between state agencies that provide similar services to the elderly and those with developmental disabilities. And finally, and not least important, the unique emotional needs of family caregivers is often not addressed in support systems established for the general population. And while there are a small number of specialized groups around the country, the number of caregivers whose emotional support needs are being met is still quite small. The council can support targeting funds to help community nonprofits enhance their programs to include services and supports to families whose loved ones are aging with Down syndrome and Alzheimer's. And I urge you, I know this was very fast, I urge you to read closely the written comments that I will be submitting, because there's a lot more detail about why I've made the requests that I have. And I thank you for staying late and hearing what I had to say. Thanks.
Thank you so much. We have 2 more virtual comments, and then any comments that were submitted to be read today, we will be sure to share them with council members just in the interest of time. So next up, we have Karen Gaffney with the Karen Gaffney Foundation.
Yes, hello. I am Karen Gaffney, and I have Down syndrome. Unlike many adults like me living with Down syndrome, we are running out of time, and we need action now. Why? Well, it seems that this extra chromosome we have puts us at a much greater risk for the early onset of Alzheimer's than the general population. And today, I am at the age where those of us with Down syndrome are most vulnerable. And quite frankly, I am scared by that. I have lost several friends to the early onset of Alzheimer's disease. One was an athlete just like me. He earned a regular high school diploma. He had a regular 2-year college degree. He was a personal trainer and a public speaker. And he was only 4 years older than me. We are about to lose a whole generation of adults with Down syndrome. Adults who have overcome tremendous odds, who have broken down barriers, who have accomplished things no one thought was possible 50 years ago. It is my generation that is showing what is possible because of the work of the generations before us. But it is also my whole generation that is marching directly into the ugly path of Alzheimer's disease. We need action, and we need it now. Open the clinical trials for people with Down syndrome. Drive policy changes to allow treatment. Treat early before symptoms arise. Please save our generation. Thank you.
Thank you so much, Karen. And finally, we will wrap things up with Terry Walter from AFTD.
Hello, this is Terry Walter, and thank you for letting me speak with you today. I am an AFTD ambassador here in Northern California and also the widow of an individual who passed away from genetic FTD and ALS. So therefore, I am part of the larger community that is known as related dementias. For me, it is important for FTD to be included in NAPA and not as a related disorder, but as FTD. This will help raise awareness of FTD and the earlier diagnosis and detection of FTD, which is so important to our patients. We do not live in silos alone, and by coming all together, we can defeat neurological brain diseases. Thank you.
Thank you, Terry. Wow, after all of those powerful testimonies, we know that we are on sacred space, or in sacred space, and working really hard on 15 years of dedication, compassion, heart, science, all the rest. So I just thank you, members and audience, and our federal partners for staying a little bit past 5 to do this important work. I thank everyone for the public commentary. And if the members will do me the privilege, I will work with Helen and Maria, and we will put together our subcommittees. We'll send them out to you. We're going to have a meeting in April or May. We'll let you know that too. And then we'll start to build the framework of the mission as Helen laid out so that we don't waste any valuable time. So that next meeting we are off to the races and moving quickly. Again, thank you to Helen and Maria and Cindy for putting this meeting together, getting us started. It was such a powerful meeting, a long day, but such an important and fruitful one. So again, thank you to all, and I'll look forward to seeing everybody in April or May. Thank you.